The main finding here was that when you compare statin use to placebo, 93% of the reported side effects vanish. And
wait. Hang on. Yeah. That's so huge. Say that again, and then I'm going to make sure I understood it. This is Generation Health. We bring you the latest news, cutting-edge research, and time-tested best practices, helping you live a longer, healthier life. Dante DiMatteo, how are you doing, my friend?
Pretty good. Pretty good. How about you?
I'm fantastic. Just need technology to work as it's supposed to without complaint, and we'll be good.
But that's why you guys got it all together. It's all good.
Well, you guys do, but Josiah's not here, so I have to figure this out on my own, and that's just miserable. So anyway, what are we talking about today?
So we're revisiting two core topics that we often, cover on this show. First one being cholesterol management, specifically looking at statins. And then also we're looking at activity. So another shocker, more specifically step counts. So the goal is not to undo things that we've talked about, but just to continue to refine the instructions, the information that we give as new sort of information is presented to us. To give you a lay of the land, again, we're going to be looking at the nuance of statins, and we're also going to look at the kind of the intricacies of step counts as the two overarching topics.
Love it. Okay, so the statin thing first. Is this the big meta-analysis that came out about side effects?
That's correct. So
awesome.
It's trying to remain as current as possible with these sorts of releases. So yes, that's what we're studying, or that's what we're covering.
Awesome. Jump in.
All right. The key here before we really dive in, it's not that the side effects when taking statins never occur. It's just that this nocebo effect that we'll talk about and aging, they're often the real culprits here when people are having some of the most notable side effects of these medications. So we need to continue to stop the fear messaging around the drug so that we can, realize their full benefits. And
absolutely,
as Tyler mentioned, the primary source of this information today is the cholesterol treatment trialists, the CTT collaboration from the Lancet. Looking at, I would say, what was the number? Like over 100,000 people. So
massive study.
Yes. Kind of the lay of the land here with the statin meta-analysis is that we have 30 years of data, yet we still have this fear around certain package insert side effects. This particular collaboration looked at individual data from 19 double-blind RCTs, and this was over 123,000 patients.
Wow.
The main finding here was that when you compare statin use to placebo in a blinded setting, 93% of the reported side effects vanish. And
wait. Hang on. Yeah. That's so huge. Say that again. And then I'm going to make sure I understood it.
So the main finding in comparing statins versus placebo in a blinded setting, we see that 93% of the reported side effects vanish. There was so we'll get into what those are.
Okay, but what you said is that when placebo-controlled double-blind studies were used, 93% of the reported side effects from people who thought they were taking statins disappeared because they were also having the same side effects if they were on placebo. Is that the way that works? Okay.
Exactly.
All right. Wow. Okay. So keep going, because that's huge. 93% of the side effects.
So they found, it's important that we talk about which side effects are in question here. They found no causal link for sleep disturbance, memory loss, or any sort of cognitive impairment. They looked at, there was no link with depression or sexual dysfunction as well. So the nocebo effect that we talked about, people were basically getting they're experiencing some of the symptoms that were are those that are reported in package insert and stuff that are things that are, commonly cited. It was more reflective of their aging process, and because of the expectation that the drug can cause these things, versus the sole mechanistic, chemical cause of the drug.
Wow.
So, I think
the brain is so powerful. That's crazy.
It is. And I think, before people get upset, like we can talk about what is real. So what's real here? What are as a refresher, what are the confirmed risks that we know? As any intervention is a trade-off, of these pros and cons, and also can the potential benefits outweigh some of these smaller downsides. So this is always at the forefront of these decisions. It's not that this is void of risk after, looking at this huge meta-analysis. But let's just be honest about what the drug does do. So people are probably wondering about muscle aches. So the muscle pain or myalgias, they are real, but they are rare. The absolute excess risk in this case is less than 1%. In the first year. So most of these muscle aches that people are experiencing, this is more as a result, again, of aging, expectation potentially, or other factors, not the statin. Diabetes is a big one, or changes in blood sugar. This is that, again, that there's a moderate to we'll say, dose dependent increase in new onset diabetes when starting a statin. Now, this is mostly in those who are on that threshold of pre-diabetes anyway. So again, a little bit of an instance where you kind of have to live in the gray. Would these people have developed, a more developed form of diabetes regardless of starting the statin therapy? It's hard to say. This is another instance where, kind of an individualized plan is necessary. The last sort of real side effect that we're accustomed to seeing is the signal of elevated liver enzymes or transaminases. Very real occurrence, but this is rare that this is something that's developing into actual liver failure, hepatitis, things along that vein. So it's more of a biochemical number on a page as opposed to an actual disease process occurring or any sort of damage that's occurring. Usually it's not that, that this wouldn't continue to be monitored, but again, it's very rare that we're seeing this progress into additional issues.
Okay, so I just want to recap real quickly. You said the actual legitimate, verified, confirmed, there are possibilities of these side effects for taking statins are muscle pain, very rare, about 1%, something like that. New onset diabetes, but generally speaking, these are folks who were already kind of on the cusp. And so this is maybe the thing that just put them over the edge. And you said liver enzymes, but it's not typically pushing into like serious liver issues.
Correct.
Okay. All right. What are the things that were previously warned of that we've now confirmed are not related?
When we mentioned that 93%, that big scary number at the beginning, the study looked at 66 different side effects. So 62 out of the 66 possible side effects had no statistically significant link to the medication use itself. And so these were the, popular complaints such as, again, memory loss, dementia, depression, sleep disturbances, erectile dysfunction, sexual dysfunction, weight gain, headaches. So,
those are heavy hitters.
It's yes. And those are all things that are admittedly hard to flesh out anyway. Is it a different medication that's being used? Is it a different condition that you have that's not currently being managed? Or is it a downstream effect of a condition that you already have that is being managed? It's no easy task sometimes investigating where these come from, from the beginning, but from a statistical perspective, looking across many respectable papers in aggregate, we can more confidently say that, yeah, it's probably not the drug.
Got it.
So
okay.
The other interesting side effect that I think, if we look at maybe some of the negatives that this paper brought about there, we can do a quick deep dive on the kidney issues that were identified. And so the observation, was basically that high intensity statins, so rosuvastatin, atorvastatin, and, their associated higher dosages had the potential to cause microalbuminuria, or basically just protein in the urine.
Okay.
And so we usually think, all right, this is something to panic about. The kidneys are failing. Now, rest assured, this is largely a false alarm, but it is worth mentioning. So there's a whole kind of complicated mechanism by which this occurs based on how the drug's working, how the kidneys in certain cells are to reabsorb protein, basically. But the end result is that the kidney filter, the glomerulus, is fine. It's just that the retrieval mechanisms or the tubules are just on some sort of break, if you will. And so there's not like a functional blockade or issue that's occurring. There's not structural damage that's occurring. It's just something mechanistically with the drug that's, again, causing something to reflect or at least signal that there's something up with the kidneys. Now, fortunately, there is another test that can be looked at, because this isn't a situation where your prescriber or your care team would ignore this signal. You can have further testing done. The testing, it's not even a test that I'm sure that you would have to recommend, but it's a alpha-1 microglobulin test. And if this test is elevated, then that the statin is the culprit for affecting the tubules or the pathway or the retrieval team, if you will. And it's not the actual filter, not reflective of filter damage.
Oh, okay. So it's a simple test.
That makes sense.
Yeah. And you can figure out whether or not this is actually causing serious problems or if there's something wrong that needs to be addressed.
Exactly.
Okay. You mentioned a nocebo effect. What is that?
When we're talking about the nocebo effect, it's basically it's been described as like the evil twin of the placebo effect.
Okay.
It's so in this context, it's because the people they might have the expectation ahead of time that statins are going to cause muscle pain because they've heard their parents say that, or they've heard their other favorite podcast mention it, or whatever the case. So there's an expectation going into the treatment, or whatever it is, brain fog, whatever the effect in question is. Mm-hmm. Their brains effectively amplify those sensations. So you just trick yourself going into an intervention already knowing that it's going to negatively affect your course of care. Placebo effect is that, you might be taking this inert or inactive substance, but because you have the expectation, you've heard it's really great, heard it works really well for people, that you go in, this is going to work great for my low back pain, this is going to work great for whatever intervention is. And then, it does show that result, but was it the inert substance, or was it the real thing? Was it your brain? The nocebo effect runs counter to that.
Okay. So, but the bottom line is it's still mind over matter. Something, for some reason, expectations are changing the way you experience what's happening in your body.
Oh yeah.
Okay.
Expectation. That's a great way to put it. Expectations are very meaningful, especially in the context of medicine, intervention, you name it. It's going to play a large role.
Okay. Dante, we've been using statins for decades now. Why did it take a huge study of 120,000 people to figure out that statin brain and muscle aches and what was real and what wasn't? Why have there been so many of these false alarms coming from statins if they're generally safe?
Yeah, I mean, that's the $1 million question. I don't have a perfect answer for that. It's just that a lot of the earlier conclusions around these, sorts of side effects, they were largely observational studies. So there weren't always interventional studies aggregated together to flesh out these particular outcomes. And so I think a lot of people had a really good idea that this might be the case. It's just that they weren't, in the absence of a meta-analysis of this scale, I don't think they were as willing to put their foot down and just say, hey, we can say pretty confidently now that this is the case. So again, it's not that this is brand new, just pulled out of the sky and suddenly we have 20 interventional studies to look at. No, these have been around. It's just that there was a humbleness behind, asserting some of these claims, a little bit more conservatively.
Nothing wrong with humility. That's always a good thing. Mm-hmm. Okay. Well, the big question, Dante, now that we have this massive meta-analysis, we can confidently say that, 62 of the 66 reported symptoms are not realistic or real or coming because of the statins. How does this change things in the pharmacy level? How's this changing things in the prescriber level? What's changing there?
So that's another great question. The biggest thing is the initiation dosing, I think. Well, we see is maybe a little different now. Because of the psychology around the potential issues of statin and the potential for it to cause the muscle pains that it caused my grandfather, or the potential of these blood sugar issues, or whatever the case, it was this, I think on an individual level, was this conversation of, well, hey, like we'll start you on this low dose and then we'll see, and then we'll wait, and so on and so forth. Now it's like, well, hey, we know that there are some real risks associated with this, but we know that those risks they're not that big of a concern in comparison to the possible benefits that we see. So it's like, hey, instead of starting you on this low dose that's like psychologically feels better, we're going to put you on the dose that you probably should be on, which is maybe a higher intensity, because we know lower cholesterol for longer is better. And so I think that, not only are we getting people in the door faster with treatment, we're getting people up to the meaningful dose of something that's actually going to move the needle for them. So it's interesting in that regard. We're seeing earlier intervention now. Guidelines have changed, like we've talked about. We're seeing, again, earlier initiation in people with risk factors. We're looking at the other risk factors like familial history, things like Lp(a), which is important because we are trying to lower this lifetime burden of exposure to these harmful, particles, basically. Now, if you're somebody who's on a high intensity statin, we were not just going to keep upping the dose
ad infinitum.
Yes, we're not going to increase the dose ad infinitum. So, so now we are more likely to see these combination therapies, and that's where things like Zetia plus statin come in, statin plus PCSK9 inhibitor, Repatha, those medications. Instead of just maxing the dose of these drugs, or if you're on an older agent, just continuing to increase that. That's where you see the risk of side effects start to increase, is when you're like pushing the upper limit of these doses. High intensity doesn't mean maximum dose. It just means we have good data that this higher dose has the ability to really move the needle. So a lot of this stuff is already happening. Again, this trial did not suddenly inform guidelines now and everything changed. Practitioners are already sort of operating under the assumption that a lot of this is true. And so I think it just helps the average person. It helps the patient understand why maybe you're on a second cholesterol agent, why maybe you're on 40 milligrams of atorvastatin instead of 10, because I think I would mentally feel better about this dose, so I think it's just just further it's just another line of converging information supporting some of the hunches that we had.
I mean, I know that statins are our biggest and best weapon pharmacologically in the fight against cholesterol and all of the heart and brain issues that can come about because of clogged arteries. I'm glad to see more confirmed data showing that nope, they actually are very safe and very effective. Let's get more people healthier longer so they are sticking around. Okay, give me the update on step counts. I pay attention to mine. Not doing as hot as I'd like today. Hopefully the number's going to come down. I only have to hit 2,000 steps and I'm healthy.
Yeah, so there's another paper came out in October of 2025, step accumulation patterns and risk for cardiovascular events and mortality among suboptimally active adults. So another just banger of a title.
Always, yeah.
And again, I think similar to the statin portion, we're just refining kind of our understanding on maybe our step count goals, what the number should be, why maybe 5,000 steps for Jane might be different than 5,000 steps for Steve. And so that's what, essentially that's what this research helps us understand a little bit better.
Okay.
Some of the context here is that the physical activity guidelines in their most recent iteration removed some of the language around 10-minute bouts of exercise being the requirement. And they shifted this to a more, every minute counts sort of perspective, that exercise snacks are a valid form of exercise, that, just telling people however you can get it done in whatever quantity, that's what matters. That is certainly still true. It certainly still rings true, but now we have some more observational data that maybe challenges how, stratifies what would be the difference of somebody who's more of an exercise snacker versus more of a, 10 plus, 20 minute plus dedicated window of exerciser. Okay. So, looking at the new news here is basically that, total volume of exercise or step counts as a proxy of general activity or exercise. Volume matters. The total matters. It's just unfortunately how you get it matters maybe a little more than what's being recommended. So looking at the study itself, if we look at the suboptimal group, there were about 33,000 adults, suboptimally active, averaging less than 8,000 steps per day, which is a, common recommendation at this point, depending on where you look. They categorize them basically how they got their steps. So in either short bursts, which is mostly less than 5-minute bouts, or intentional walks, which is greater than 10 to 15 minute anywhere from like 10 to 15 minute bouts of or more of walking or exercise. Sure. If we look at the results, we can frame this, as person A, person B. Both of these people, they walk 6,000 steps a day. Person A, they're the classic, hey, I get my activity by doing tasks around the house. This is cleaning, walking to the fridge, going up and down the steps, that sort of activity. Maybe, maybe some gardening, whatever the weather allows for, that sort of archetype of activity person. Person B is the walker that everybody knows. They walk all the time. They walk everywhere. They go nuts without getting their 20 minutes of walking in for the day. And so this person is getting at least 20 minutes of walking, plus some of that life movement. But we still see that, again, both of these people are getting but these people are both getting 6,000 steps a day. What are we seeing in terms of results here? The long bout person, the walker, they had an 83% lower risk of death and a 68% lower risk of cardiovascular disease as compared to what we would consider that person A, just kind of daily life around the house sort of mover.
Oh my gosh.
So an effect size like this is staggering, in a paper like this. It rivals what you would see in a trial looking at drug interventions. So it's a big deal. It's a big deal. The key thing to understand here, though, again, is this is observational. We can't draw any sort of causative, perspective on this. But again, it's certainly is eye-opening and certainly does help us, begin to flesh out the different types of activity out there.
Not all steps are created equal.
Mm-hmm.
Why is that? A step isn't just a step. Why is it that consciously doing it for 15 or 20 or 30 minutes has such a profound difference in things like survival rates, mortality, and heart events?
We know that the short bursts, the snacking, exercise snacking, those are great for breaking up sedentary time, breaking up, the desk job sort of situations, the work from home sort of thing. This does help. We have other data saying that this helps manage, blood sugar, insulin responses. It's not that this is doing nothing. It's just that in order for us to get the sort of cardioprotective effect of exercise, in order to actually change the physiology of the heart rate variability, vagal tone, the sheer stress of the endothelium in the heart, those sorts of things, you need a sustained effort. It's basically the engine has to be running long enough for physical changes to occur. And that's, I think, the most basic end of the why of the physiology and the difference between the bouts.
So you're saying, I think you just said it, it has to be a long enough bout of intensity, whatever that intensity level is, that it actually drives adaptation, that shorter than a certain point, the heart doesn't, all the muscles, all the things that need to adapt just don't get the message that it's time to improve.
Right.
They go, well, we were sufficient for this very short task. No need to change.
Mm-hmm. Yeah. It's almost, you have to think of it as almost like not to get too meta about it, but it's like, what sort of signal are you sending the heart? Like, what sort of signal are you sending the body? If you are somebody who's already moderately active around the house, you're getting 6,000 steps a day from doing those, tasks that sometimes we all hate to do, cooking, cleaning, taking the garbage out, those sorts of things. Not that those aren't doing anything for you. It's just that we are probably well adapted to those, whether you would like to believe it or not. And so the signal simply is not strong enough to kick your heart into a certain mode, that's going to elicit there's not enough stress that's going to elicit these, again, physical changes that we're looking for. It's almost like if you're somebody who is, again, 6,000 steps mainly from doing stuff around the house, it's like background noise when you start to add exercise snacks. It's almost like your body thinks, possibly we could like hypothesize that if you go for a 2-minute thing, your body might just assume, oh my goodness, that's just like when you take out the garbage. That's just like when you are changing the sheets. That's just like when it's not, the signal is not strong enough, unfortunately. And so it brings us to kind of this, the practical application of this is that if you're stuck in what you perceive or has been recommended or what you've read about is this low step range, this 4,000 to 6,000 step range, conventional wisdom would tell you you just got to do whatever you can to bump up those steps. So do more fidgeting around the house, do more stuff around the house. Yet that's not a bad move, right? It's not bad. We still know that the total volume matters. It's just that we need more consolidation. You need to find like a fragmented time where there's a 15-minute clock running where the intensity or the effort is that much more above what you are already doing otherwise. Yeah. So it's less about just add this 1,000 steps. Well, if you can add 1,000 to 2,000 steps in a, 10, 15-minute walk or run or whatever the case, that, at least based on this data and what we kind of recommend anyway, is going to be the driver of changes at the level of the heart, changes in terms of your, risk, the risk profile that you have for cardiovascular disease and such.
So stop snacking, eat a meal.
That's right.
Well, folks, if you learned something today, we would love it if you would share this episode with somebody that somebody else who could learn from this information. Share the episode here on YouTube or on Spotify, Apple Podcasts, Rumble, wherever it is you listen to your podcasts or watch them. Share the show with somebody you know. Leave a comment. We love those. We always answer comments. And if you have a question, you can drop those in the comments as well, or email us, questions@askjoedimatteo.com. That's questions@askjoedimatteo.com. That website is also where you can find past episodes of the show or the show that started all this, the Ask the Pharmacist show, as well as all of the wonderful supplements and products we sell there on our website. We don't take sponsors. We don't sell t-shirts yet, but we do have a whole lot of fantastic supplements. Go check out our website. Get yourself some omegas, some probiotics, some protein. It's all great stuff. Thanks to everybody who helped make this happen. And I think that's it for this time. We'll see you next time.